Welcome everybody to the third in our series of webinars for our Nursing Reimagined series. My name is Helen Aviard and I'm the programme lead for the Professional Doctorate in Nursing and Midwifery here at the Oxford School of Nursing and Midwifery. In our previous webinars, we have shown how our doctoral students tackle deep and sensitive issues around which nursing practice so often revolves. We have discussed our research involving the carers for both children and those with mental health conditions. And we have looked at our research in terms of the importance of the fundamentals of care and how to think differently about how certain placements might promote students learning about the fundamentals of care. In this webinar, we are looking at yet another important area. We are discussing two projects which have been focusing on tackling inequalities in both access to research and access to nursing and midwifery education. Firstly, Jade, one of our doctoral students, will discuss her project looking at widening participation in midwifery education. It is important to say that Jade's work is part of a team, and Jade will discuss this, who sought to identify and break down barriers to a more inclusive approach to accessing midwifery education. Following this, Dr. Claire Coughlan will report back on her doctoral project, looking at the inclusion of a wider range of participants from diverse groups into research, looking at research into uptake of bowel screening. Both of these projects address the inequalities that exist both in education and research. Tackling institutional embedded practices that lead to inequality is not easy, but we will hand over to Jade and Claire to let us know how they are tackling this. Thank you, Jade.
Brilliant. Thank you, Helen, for the introduction. Good afternoon, everybody. My name is Jade. As Helen just said, I'm a midwife by background. I'm a senior midwifery lecturer here at Brookes, and I'm also the admissions lead for the midwifery programmes. I'm also in my final year of the professional doctorate in midwifery. Although, as Helen just said, I'm not talking about my doctoral project today, because if you know anything about my doctoral project, if you were at the symposium in January, you know that that project is on the female perineum, which is not quite what we're here to talk about today. So I will be talking to you about this project, which is a project I worked on as part of this team with some other midwifery colleagues. And we looked at the experiences of GEM, midwifery applicants and students. And when I say GEM, I mean global ethnic majority, as we're trying to leave the word BAME in behind. So we're looking at the experiences of GEM midwifery applicants and students in the southeast of England. And before I go into the project, I'm just going to give you a little bit more context in terms of where the study sort of started, and a little bit more about midwifery in general. So some of you may know that in midwifery and maternity care, we have two main issues at the moment when we're thinking about underrepresentation or inequalities. First of all, we have the fact that Black and Asian women are more likely to die in pregnancy and the postpartum period. And this is often, not exclusively, to do with language and cultural barriers and discrimination. And beyond that, so beyond the first issue that I've just mentioned, we also have the fact that midwifery tends to be quite a white profession with very little diversity. So just bear in mind these two issues we have at the moment in maternity care. So this project was born because Karina, some of you might know her, she's the EDI lead for maternity at OUH, and it's unfortunate she couldn't be here today because she was working, and she's also doing the Masters in Research at Brookes, so I'm fairly sure some of you might know her. And it all started when Karina, when she qualified a few years back, I think 2019, went to Louise, who was our former midwifery programme lead, asking her to work together on increasing GEM representation in the midwifery cohorts. We might not be able to fix the increased maternal mortality for GEM populations as a whole in the UK, but we can fix the issue around recruitment, but that can be addressed. Just to give you, again, a bit more context, when Karina qualified in 2019, she was one of two Black Asian student midwives in that cohort. And when we are thinking sort of, a few years back, the average in terms of GEM students, we're talking about 5 to 15% of the whole cohort. And if we look at the local population of Oxfordshire, in terms of ethnicity, it's quite below the average. We're thinking about 23% in terms of average of GEM versus Caucasian. So we were sitting significantly lower than what it should have been. And it clearly sort of highlighted some potential inequalities in terms of the way we were recruiting. And that's when I was brought in, as I'd recently started at Brooks, and I was given the role of admissions lead. So I was brought in to work alongside them and lead one strand of the research. And as we mentioned earlier, this was a team project. So we also had a couple of other members of the midwifery team, Ginny and Jane, at different stages, helping out with the project. So let me tell you what we did in terms of the project. So again, we wanted to work out what the experiences, examine what the experiences of GEM applicants and student midwives were. And we did it across the Southeast, so it was us and other two universities. And we had two main sources of data. Obviously, we had all ethics approval and all of that done. So I led on the online survey, which was sent out to all the applicants that were interviewed by the three universities. We had about 35% response rate and had just over 100 GEM applicants, about 300, just over 300 Caucasian applicants. And we think we've got over 400 responses to compare. Karina predominantly led the focus groups, in which she had 13 student midwives and newly qualified midwives. And this was so invaluable because she could really dig deep and facilitate those discussions from a place of understanding, because she was able to connect with the participants because of her shared experiences. So it was invaluable to have her part of the team. So I've put the couple of pictures of the publications that we the two publications we've got. So we'll put them in the slide so you can have a little read, because obviously I'm going to give you a bit more of a summary today. But in thinking about the findings, so the first item was around sort of finding out and getting in. Because we know that usually, open days are a quite good way for applicants who come to the university, have a feel for how the university looks like, the course looks like, and just get them a bit more interested. However, what we also found out is that a lot of GEM applicants, for them, midwifery wasn't even on their radar. It wasn't an option because of their lack of social capital. Which meant sometimes that these applicants were dissuaded by their families or college tutors from pursuing midwifery, because it was seen either as too selective and difficult to access, or not prestigious enough compared to maybe going to medical school. So, and also, sorry, to add to that, some of these studies participants also reported that they had this preconceived notion that nursing was better suited for Black applicants and midwifery was seen as predominantly a white profession. And beyond that, so thinking about the application process and the entry requirements, most universities do offer a contextual offer, which is a sort of a lower entry tariff for those applicants that are at risk of being academically disadvantaged because of their background. So we already do that. But beyond this, some applicants, which were especially those ones who had been educated overseas, were also finding stumbling blocks in terms of getting their qualifications recognised by the admissions teams. So that was an additional challenge for them. And then when we thinking about sort of the selection process, because according to, well, we're all nursing and midwifery, we're all regulated by the NMC. And we all have to interview applicants. So the interviews generally, according to the university, have a different format. But back then, when we were recruiting our participants and collecting our data, it was all online because it was during and just after COVID. So we found out that GEM candidates generally tend to appear less forthcoming in group activities, so especially when there are service users involved. Or, for example, they didn't prepare for the interview, maybe using more standard resources like maternity reports or research. And the applicants, the GEM applicants, said to us they needed to crack the code during the interviews. They had to learn the buzzwords or specific ways to answer questions to present themselves differently and to be successful, which unfortunately sometimes success comes after a lot of unsuccessful rounds. So they had to keep going, be persistent. The second theme was being an outsider. And as I said to you before, like midwifery is perceived as a very white profession. So there was this whiteness that the participants found in midwifery cohorts that seemed to be more prevalent compared to other professions like nursing. And yeah, so sometimes you had a Black or Asian student that was the only one or one of very few people in the cohort that were not white British. And these applicants and students said that they sometimes also felt excluded from the very beginning because maybe they're white. The white students sort of had linked up on social media beforehand, and they sort of already starting feeling like an outsider. They said that generally midwifery lecturers had a generally inclusive mindset, which was good because the GEM students were able to express their opinions at university. But sometimes, especially when the conversation was around race and culture, this was a little bit more tricky to navigate. And we have GEM students not wanting to contribute to the conversation on inequalities for fear of standing out, for example. The third theme that we had, it was prejudice and discrimination. Generally, GEM students have reported finding sort of being exposed to some discriminatory behaviour. And it went from sort of feeling like other or feeling as if they're different and having to change things to be accepted. And there was quite a little bit around the names, even when, for example, a Black student had a simple, familiar, sort of more white British name and being told, oh, you almost like you shouldn't have that name because that name is too simple. So being sort of having this issue around the name. And GEM students also said that sometimes it was really difficult to recognise if there was racism. Because whether the person who was sort of talking to them didn't know they were doing it, or because they were trying to disguise their beliefs, so it was a bit difficult. However, there were also incidents in which there were episodes of racist care. For example, where students have witnessed Asian women not being given effective contraception and having been explained properly, or Black women not being given pain relief, or just generally some unkind comments on sort of laziness, maybe based on race, or to the extreme when effectively some offensive language was used, and students witnessed that, which is obviously, unfortunately, very sad. The last theme is nowhere to turn. So we've had some participants saying that they were not aware of any systems in place for reporting discrimination or racism. Some others said that they had some supportive midwives or lecturers that could talk to. However, bearing in mind that midwifery tends to be quite a small and interconnected world, they felt that being a bit more of a barrier. So they felt they couldn't always raise concerns, especially, for example, maybe they would have raised them but anonymously, because being such a small, one or two people in a cohort, they were so easily identifiable, and they were worried that perhaps them speaking up would have caused them being penalised as a result. So well, now we're going to move on to the recommendations. So the first one is around reducing barriers during the recruitment process. So our approach to reducing the inequalities has been multifaceted. So for example, when we're thinking about the group activity with the service users, we now encourage all applicants to contribute with one question just to make sure that nobody's disadvantaged. Or, for example, when we're thinking about the more generic questions that we ask at interviews, we want to make sure that we allow applicants to showcase their preparation via more modern means, like social media or listening to podcasts, rather than being so strict with sort of, oh, you must have read this bit of research in particular. On top of, in addition to this, we also have been thinking about sort of the EDI related questions that we have in our interviews, and the fact that sometimes they can come across as a little bit of a tick box exercise, such as, how would you care for someone wearing a headscarf? And that felt a bit more like, again, tick box exercise, a bit more from a wide perspective. So what we decided to do, we now send a pre-reading on inequalities in maternity care out to all applicants, and part of their interview is to discuss and reflect on the pre-reading. So we're not just thinking about it sort of superficially. We really want to understand first of all their knowledge around inequalities in maternity care, but also thinking about how will they actually face these issues should they be witnessing microaggressions. So it's kind of taken a little bit step further and have a very meaningful dialogue from the very beginning, because we're talking about the interview day. And it's very pleasing that following all this big research we led and the all our findings, we've been able to increase the number of GEM students in our midwifery cohort from what it was like 5 to 15% to now 25-28, which is a lot more in line, even slightly above the local Oxfordshire average, which is again sort of telling us that this is an effective approach. We've also been working on getting effective pathways to escalate concerns, and this is obviously more targeted towards retention of students. When we were running the study, or soon after, when we sort of analysed all the data, we hosted a big listening event, and that was really meaningful because we addressed it head on. We have encouraged students and continue to encourage students to come forward and discuss their issues with a clear plan of action. But I also have to say that personally, I found that Karina, in her EDI local EDI midwife, has improved things immensely, because just to have her, so we worked on this project together, and now she's the EDI midwife locally, it has made such a difference. Also, it's wonderful to see that lots of sort of NHS trusts are also educating their staff in terms of perhaps active bystander training. So it's a bit more on the agenda, really. And then lastly, we are working on decolonising the midwifery curriculum. So as you can see in the middle of the slide, you have the decolonising the midwifery toolkit by the Royal College of Midwives that Karina contributed to, which is wonderful. And now altogether we are working on, we're writing a textbook chapter. The textbook is on decolonising midwifery, the midwifery curriculum, and Karina, Louise and I are working, and Jane are working on the recruitment and retention chapter, which the textbook is going to come out later on this year, so it's exciting. But a bit more focused on the everyday practice. We try to go beyond the use of inclusive images in our slides, and we're thinking a bit more about, okay, what happens when our students, what do our students sort of encounter in clinical practice? And thinking from a sort of a Eurocentric approach, thinking, for example, about the APGAR score. I'm not sure if you're familiar, but it's a score to assess the newborn's well-being, which is on a 1, 5, and 10 minutes after birth. And historically, a healthy baby would have been labelled as pink, but now we know that actually not all babies will look pink. If it is not really a very clear descriptor anyway, but it very much depends on the darker skin tone, and we might be less receptive to this to identify a baby who's not well. So even like moving away from the sort of Eurocentric approach that sort of led maternity care for decades is really important. And also, as I said at the beginning, we tackle inequalities from the get-go. We talk about inequalities from the during the interview. So the first potentially the first contact applicants have with us, we're talking about inequalities, and that sort of continues obviously throughout the whole curriculum. And yeah, so and now other sort of things to consider is perhaps when we have international students, which again don't tend to be many in midwifery, we need to support them a little bit more in terms of adapting to the UK system, education system. And the last thing that sort of we're trying to do now that we have more GEM students, we are also will be able to look at the attainment gap better, because obviously when we didn't have many, it was really difficult to get that data. So now is the next step forward. So yeah, that's all me. Thank you.
Oh, thank you so much, Jade. And I think we would all commend you on taking such an important step to address this issue. And I know there will be lots and lots of questions, but in line with the spirit of these webinars where we get two speakers to give their perspective on it, we'll hold those questions and we'll go straight to Claire, and then we'll come back to questions and comments at the end. Thank you again so much. Claire, can I introduce you and your study, and over to you.
Thanks, Helen. I'm Claire Coughlan. I'm a colorectal nurse consultant, colorectal cancer nurse consultant at Lewisham and Greenwich, and I'm also the clinical lead for Bowel Cancer UK. Thank you so much for inviting me to speak on this webinar. I think this is a really interesting approach, and that was great there hearing Jade talking about inequalities and inclusion in our workforce. And I'm now going to talk about tackling inequalities and inclusion in research. And I'll talk a bit about this. This was the title. This was my prof doc. That's what I studied. I studied priorities for colorectal cancer follow-up for patients from ethnic minority groups. And I did that really deliberately because of the area that I work in and the subject matter that I'm just going to say a bit more about in a minute. Move on to the next slide, please. So as I say, I work with colorectal cancer patients. It's a fabulous job if anyone's ever thinking of doing it. Colorectal cancer is a very common cancer worldwide. In the UK, we have about 40,000 new cases of colorectal cancer each year. And it kind of works out that just under 60% of patients diagnosed with colorectal cancer every year will survive the disease, and that's been improving in recent years, and that's absolutely fantastic. Partly because of that improvement in survival in colorectal cancer, but also other cancers. As long ago as 2013, the government set out its survivorship agenda. And I know that's a date that feels like a very long time ago, but I've deliberately included that here because that's kind of where all this began. So the survivorship agenda, often called personalised care, is a very positive initiative in many ways. So for those of you not familiar with it, it's about addressing the holistic needs of patients that have had treatment for cancer and aiding them in living well after their treatment for cancer. So you have things like a holistic needs assessment where you talk to patients about the things that are important to them. You run health and wellbeing events that are like lecture style events where a physio will come and speak, a psychologist, that someone like myself will have a dietitian there. And it's about giving people the information that will help them to live well after their treatment. And patients will also be given an end of treatment summary where they're told what they might be able to expect in terms of the impact of their treatment for their life moving forward. So prior to this initiative, in my clinical practice, I was seeing all my patients face to face. Myself and the team of colorectal cancer nurses I work with, we were seeing our patients face to face in nurse-led follow-up clinics. And this was a shift away from that, where patients wouldn't be seen face to face in clinic. They would be invited to these initiatives that I've just outlined, and sent their appointments for their surveillance tests. So for bowel cancer, that's a colonoscopy, a CT scan and some blood tests. And then they're sent a letter telling them about the outcome of those tests. So I was being told we're moving to this follow-up, and I'm looking at it and thinking, right, this is great for some people. But I work in a really, in my view, a brilliant area where there's great diversity, ethnic diversity, lots of minority groups. And I'm thinking, I don't know if this is going to be suitable for all of the patients that I serve. I'm picturing my patients and thinking, well, what about them? So I looked at the evidence that this shift in policy had been based on. And what I saw was that predominantly the people that had contributed to the evidence were white British. And I looked at this and thought, well, my patients haven't had a voice. It's brilliant that lots of people have, but my patients haven't. And that really, really troubled me because I could see this was a major shift in practice. So if we move on to the next slide, please. So at that time, I was working as a nurse consultant, and as I say, it's sort of down to me that we were going to implement this change in policy that would then translate into a change in our clinical practice. And I thought, I've got to do something to address this, that not everybody's had a voice, and I didn't really know how to do it. I'd done a master's previously, but I hadn't really it was a master's in nursing, and I hadn't really had a great deal of training in research. And I knew that I couldn't do this on my own. I kind of kept thinking of ways to tackle it and thought, I'm not going to be able to do this on my own. And I just knew that I wanted to impact clinical practice and outcomes and be able to possibly influence policy in the future. With giving a voice to underserved populations in research terms. So I looked around for a way I could do it, and I happened upon the ProfDoc programme at Oxford Brookes, and was delighted when I saw it because I could see that I would get training and help, and I could see that it was structured in a way that was accessible to me in terms of work-life balance and it running at weekends. For those of you that do it will know. So I put my proposal in, and Helen won't mind me saying this, I know she won't. The team at Brookes said to me, well, what is it you want to do? And I said, I want to speak to patients from an ethnic minority background about what they want for follow-up for after bowel cancer treatment. And Helen and the team said to me, this is going to be really difficult to do. Your people do try and do this, but it's really, really hard. And can't you do this differently? Because we're worried for you that this project won't be doable. You're not going to be able to recruit. And I said, well, I can't. I've got to do it in this way because I've identified this gap for this particular population. And there are gaps for others. I think it's important to say that we know that in research, patients from an ethnic minority background, those that live rurally, the elderly, there are lots of groups who don't get a voice. The traveller population, there are lots of groups who are underserved. But this was about the area where I practice. So I was trying to gain evidence for patients that I knew didn't have a voice that I was trying to care for. So the team were fantastic and said, okay, if you really feel this is how you want to tackle it, we'll help you. And what was brilliant for me was having the support of all the faculty, but also you'd have seen the name of my supervisors at the beginning of on the first slide, and they were really good at sort of challenging me in how I wanted to do things. Don't are underserved through research, and I think it's really important to say that it's not deliberate at all. It's quite often, it may be that a research study has been done in an area where there aren't that many ethnic minority groups. So for me, there are lots of ethnic minority groups in the area that I work in, but that might not be true in another area. So it might simply be that people invited to a study don't live in the area where the study took place. Or it might be a geographical issue in terms of people had to come somewhere to be interviewed or spoken to. So there are lots of different reasons. Funding is another one. I'll say a bit more about this at the end, but you do need some money if you're going to, for me, it's important to speak to people from ethnic minority backgrounds, but that nobody should be excluded because of language. So I knew I was going to have the services of translators for this, and that takes funding. And I'll say a bit more about that in a minute. The other thing that we know is that there is an element of cultural mistrust, and Jade alluded to it in her talk just now. When I did the patient involvement part of getting the support group at the trust that I work in to look at the consent forms and participant information for the study and discussed it with them to get their input. They're a really diverse group of patients that go to this support group, and they said to me, what's really important is that this will count, that if you ask people's opinion, because we get asked a lot, but nothing ever happens as a result of that, please don't let this be a tick box exercise. It needs to count. We acknowledged there were lots of barriers that were already that exist, and they're not deliberate. So when we looked at the design of the study, we set about trying to remove as many of those barriers as possible. So firstly, translating materials. I knew that I needed to do that, and I knew I needed the services of a translator. When we applied for ethical approval for the study, we didn't know if it'd get through ethics actually, but it did. We made it that I was really fortunate. I had two centres, and there were two clinical teams that were helping with study recruitment, one in the Southeast and one in the Midlands. And under the terms of the ethical approval we gained, those clinical teams just had to ask patients verbally for their consent to provide me with their contact details and their address and their language spoken. And that meant they didn't have to take any written consent for me to be able to get the appropriate materials translated into the appropriate language, send them to the patients, and then ring the patients, if necessary, using a translator. So they took out that first initial barrier. We took that out where somebody might have to sign a consent form for me to contact them. We fortunately were able to gain ethical approval for the patients to give their verbal consent. And that was really important. So it wasn't easy to recruit to, I have to say. I got 19 patients to agree to be interviewed about what was important to them about colorectal cancer follow-up, for their follow-up. I had to get an extension to get 19 patients. I had to have 6 months extra added onto my study. It wasn't easy. Really interestingly, lots more men consented than women. And I hadn't expected that. But it was really difficult to get women to participate in this study. And the women that did participate, two ladies in particular that couldn't speak any English, and I'd obviously had the materials translated and spoke to them via a translator. They had never before been spoken to about their cancer diagnosis in their own language without their husband translating. for them. So their husbands had acted as their translators. They'd never had a professional translator all the way through their cancer care. And this was the first time that they had had that opportunity. So you can probably imagine they told me all sorts of things during those interviews, because they were at last able to speak through, themselves, through a professional translator. So if we could move on just to the next slide, please. I think what I would say is that there was lots of learning from this, and we're just in the process of publishing the findings now. We found some of the findings didn't surprise me at all. So I'll just summarise them for you briefly before we talk about the learning. So the patients did say they wanted to be seen face to face, that they found it really difficult to talk about deeply personal and intimate issues over the phone. So removing that face-to-face contact was detrimental to them being able to talk about their physical and psychological and social well-being and healthcare needs. The translation issue came through really strongly, that people wanted to have the services of professional translators. Culture came through strongly. People talked about, for some people, they said that it was their ethnicity and their culture weren't important at all in their cancer care, and for others they really felt strongly it was, and they were very concerned about their own communities, and they recognised cultural barriers in accessing healthcare. So and they had all these ideas of what they wanted to do to help address that. And the importance of faith came through really strongly in this study. So if this is something you're interested in, there's lots written about that, and we will publish the findings of my study for it to make a difference. The overall learning, I would say, is that it wasn't as hard as we thought it would be. You had to really think about it in the design of the study right from the start. And if you're interested in this, you will have seen NIHR's inclusion strategy that is running till next year to try and access underserved populations in research. And one of the things that they talk about in that strategy is targeted research, targeting populations that don't often get a voice through research for a multitude of reasons. And that's very much what this study was about. It is possible to improve access to research studies. If you're in clinical practice or you have links with clinicians, you can absolutely do this. And I would say that that's what made a big difference for me, was that I was working with clinical teams who were already trusted by the patients. So when they approached them and said, please, will you consider being a part of this study? They would consider it because they already had the trust of they already trusted the healthcare professionals that spoke to them. The other thing we can do to use improve access is to use a translator. So I used Language Line because that was the translation service used at the trust that I work in. I used them to translate the materials, and you need funding to do that. It cost about £500 for each set of translated materials. So you do need some money. I was really fortunate, and actually I don't believe I would have got my job as the clinical lead for Bowel Cancer UK without the Prof Doc. During my time on the Prof Doc, I went on secondment to become the clinical lead for Bowel Cancer UK, and now have a dual role as a nurse consultant and clinical lead. And I don't think I would have got that job had it not been for this Prof Doc, so I just wanted to add that. It really opened up avenues for me that not only enabled me to get some additional funding for this research, because Bowel Cancer UK funded the translation, but also to make the research count. Because through my role, I've been able to, one of the things that people told me is that they were not given information in their own language. So they couldn't read it themselves because it wasn't in their language. So one of the things we've been able to do at Bowel Cancer UK is begin to translate materials so that nurses can take them to clinic and hand people information in their own language about their own disease and their own care. So I think that's been a really important important part of this study for me. But you do need some funding. But with all of those things, you absolutely can make a difference. You can ensure that more people have a voice in research than have before. So, thank you.
Oh, thank you very much, Claire. That was such an interesting and thoughtful account of your study. Thank you so much, and thank you so much to the both of you. And we'll open up to questions and comments in just a moment. But just a few things that I was thinking. What is so striking about both of your talks there is how the both of you identified issues from within the organisation, didn't you? And did something about it. And I think that really reflects how important research is, and that it comes from genuine issues in the clinical or the educational area, and that people like yourselves, it's so impressive, have the energy and the enthusiasm to take it forward, especially Claire, when you say that people like myself that said there are easier things you can do, and I absolutely stand corrected on that. Sophie, do we have any questions in the chat?
So no questions in the Q&A box so far. So if anyone does have any questions, please feel free to submit them there.
So meanwhile, Jade, why do you think midwifery is traditionally less diverse than other healthcare courses?
Yeah, I mean, based on what our participants have said, it seems to be that because it's so selective for a lot of even the participants' college tutors were saying like it's so selective, don't even try it. So I think that's the idea that's is generally like we don't have big cohorts, and so it makes it more difficult to get in, and maybe sort of recognizing that they were coming already from a slightly disadvantaged background. They were just saying like don't even try, or because especially there's a piece of research who was conducted in London by someone sort of looking at similar issues, and they were saying, especially from the Asian community, midwifery wasn't a particularly prestigious option. So if they were thinking about healthcare, it had to be medicine. So it was really kind of varied, really, in terms of what the participants have told us. So it kind of seems to be whether it's too selective or not prestigious enough. So, which is really interesting, because they were making that sort of connection with nursing, and say actually we think that nursing is more appropriate for some reason. So it's that's what they've said.
Oh, thank you. Claire, if there was one thing you could change about widening participation in trials, this might be a tricky question. What would it be?
I think one thing, can I change too? There's a few things I've changed, but I think allowing clinicians more time to speak to their patients about participating in research and why it's important, I think would be the one thing. And then with that, you would get use of translation services, because quite often, I know from working in clinical practice, and I'm sure lots of people on the call will, if somebody turns up with a family member who says, "Oh, I want to translate," you just do it because it's quicker. But actually just having that time to say to somebody, would you be interested in this study? And I think that if we were able to have more time, it would make a difference to qualitative studies, but also to those, we know in cancer care particularly that people that participate in clinical trials do better, they live longer. And we also know that there are many populations that have much poorer access to clinical trials. And a lot of that is about the time it takes to explain a clinical trial to people, and being a trusted healthcare professional that does it. So handing someone onto a research nurse that they've never met before, or a research nurse that's not embedded in the team, perhaps isn't always the best thing. What you need is the specialist nurse or the consultant that cares for that patient to have more time to sit and explain it.
Yeah, oh, thank you. And I guess it's fair to say that there's is a lot of it. There is a little bit more attention to wider inclusivity in trials. Do you feel that your research has been able to make any impact in that direction to address any of the issues that are coming up?
I think certainly in my own trust, it's encouraged people to have better translation of materials about trials, and to ensure that you use translation services. So I think at that level it has. I think I've presented this a couple of times at colorectal conferences, and I've had lots of questions from nurses and others afterwards about how to do this. So I would like to think so, and I hope once I publish it as well, that will really help, because it genuinely, as long as you've got the design of the study right, it wasn't that hard to do. But
Yeah.
it's about the design of it.
No, thank you. And I
There's
think as
there's
well,
oh, sorry, just to jump in there, there's quite a few questions now in the Q&A.
oh,
So just to make sure we've got time to answer those. So one of
no,
them was from Heather Slade. She said, interesting that face-to-face is more acceptable to your research project, Claire, than phone calls. How could we improve inclusion if no face-to-face translation services are available due to cost?
So I think I know it's difficult because of cost. I think that so I used Language Line. I didn't use face-to-face interpreters. I used a telephone translation service, which is cheaper to use. I think the thing for face-to-face appointments is, and you can't. It's interesting because a lot of the other studies show that telephone follow-up is more acceptable for a variety of reasons. People prefer not to have to go to hospital. They don't find it that convenient. They don't want to lose time in work, particularly with younger people being diagnosed with cancer. So I think it's interesting that it was so different. The finding was so contrasting. I think what I find in my own practice is if you have a couple of really good face-to-face consultations using a translator in the first instance, you can then move to telephone if as long as you do the touch points. The patients in this study pointed out to me that they were being told to pick up the phone and ask if they had help, and they couldn't speak the language to do that. So I think you have to, there are ways around it. I think first of all, you have to establish that really good, for me, it's about the nurse-patient relationship. And I think you need to establish that really strongly early on if you can. And face-to-face interactions for some populations will be the way to do that. And I think it's a false economy to not do it, because you will find that you will end up, for example, I'm sorry because it's bowel cancer specific, but that's what I do. You will end up with people sort of bouncing into gastroenterology departments because nobody's addressed the effects of their treatment, because they haven't been able to tell anybody. And eventually they'll end up being referred through a route that they don't, and having a load of tests they didn't need to have, or having repeated colonoscopies to check for recurrence, because nobody's ever taken the time to find out what the actual cause of the issue is. It's not recurrence, it's a multitude of causes that lead to incontinence, change in bowel habit, anxiety, all of those things. So I think it's a false economy, and you have to establish it at the start. I proposed a care model as part of the findings, where more and more trusts now have cancer support workers, and where cancer support workers ring patients that are identified as at risk of not a poor patient activation. It's called, but it's not their fault. It's just that if you can't, I can't ring and ask for help in Portuguese because I don't speak it. So if you identify that that's going to be an issue for somebody, you ring them. You get your support worker to ring them with a language line interpreter. Does that answer the question?
There was also a question from Jacqueline Hunt, who said that, Claire, what differences will Bowel Cancer UK make to their online resources as a result of your studies? I don't know if you've had those discussions yet, or
Yeah, no, we have. So we're translating the materials now for online and for distribution to the nurses. And I have to say, we got some funding for it, and we've got a thing called the National Colorectal Cancer Nurses Network. There were really active groups, over 1,000 colorectal cancer nurses in it. And we asked about the most common languages. So we've started by translating those resources. So yeah, it is making a difference already. We are beginning to translate. The other thing I would like is we have something called an Ask the Nurse service that at the moment is predominantly an email service, but patients can be phoned. The nurses can ring the patients. If someone rings the charity and says, I want to speak to a nurse, the nurses can ring the patients back. And I'm just trying to work out a way to make that available more widely, given language barriers. We're looking at that now.
Great, thank you. Yeah, so many great questions here. I'm just making sure I'm hopefully we can answer most of them. There's also, so I'll just focus on the questions for Jade at the moment. It's from Anonymous. I'm not sure who submitted this one, but they're wondering whether there's an element of mistrust from Caucasian population towards non-white midwives, as childbirth is such an intimate but also anxiety-provoking experience. Is this something you've come across? So that's the question for Jade.
Yeah, I don't think we've come across anything like that. I think the majority of the experiences that students and newly qualified midwives were discussing during the focus groups were predominantly about sort of them being in placement, so the relationships with their supervisors or sort of the broader NHS, rather than necessarily issues with women, really. So that's something it probably could have happened, but it's not something we found out during our focus groups.
And there's also another one for you, Jade, from Ginny.
Yeah.
So she's asking, are there any other plans to repeat the study given the positive changes that you've made at Oxford Brookes?
I mean, wouldn't that be nice? It would definitely be nice, but this was a quite big project. So maybe, yeah, it would be really nice in the future to maybe go back and look at things. I'm very pleased that even sort of looking at the number of GEM students as they were before COVID to now, they've changed massively. So it's wonderful. It would be really nice if we could go back and maybe explore in terms of focus groups, maybe a little bit more. That would be great, but we all know resources are limited, and yeah, time and all of that, but yeah, it'd be nice.
And there was a question from Charlotte. I don't know if you wanted to answer this one, Helen. She said she's interested in the comment that women spoke more openly with a professional translator. How did you know that? Was it part of your questioning? It's a question from Charlotte. Don't know if you had any thoughts on that, Helen, or anyone else.
If that's referring to Claire's project, isn't it?
Yes, sorry.
Yeah, Claire,
Yeah, that's all right. So I don't. What's the last bit of the question? What was it part of the?
Was it part of your questioning? So more women spoke. So she said, "I'm interested in the comment that women spoke more openly with a professional translator." So Charlotte's just wondering, how did you know that they were talked more openly with a translator? And was that part of your questioning to try and delve into that question?
Yeah, no, it wasn't. Actually, both of the women were quite young. They were fairly newly arrived in the UK. One as an economic migrant and one who'd left a war zone. And they started to talk about the impact on their fertility of the treatment and how that had impacted them, and it was about things that they hadn't discussed before, and they didn't know how to get help. And they were the people that had only had their husbands translate for them. And I think it was really difficult for them to, just to discuss those issues that were really personal to them. But I didn't ask them specifically if they found it easier talking to me through. What was really interesting about translator, actually, but translation, and this is a whole study in itself that my team and I talked about. It'd be lovely to have the use of AI. I don't know about the ethics of it while you're using a translator, because you'd ask a question and then the participant would quite often say loads of words, and then the translator would say, yeah, they say that pain was a problem. Yeah, you'd be like, no, they can't have just said that. They've spoken for like really long time. That can't just be that they've just said, oh, it was pain, because they've just said loads of words. So that would be, sorry, that's slightly off topic of that question, but that would be a really interesting study in itself, because how do you? Because I didn't know what the translator was telling me was what the person, they were paraphrasing, I presume, but I didn't want them to paraphrase. I wanted to know every single syllable that the person was saying. So that's an interesting topic in itself. But no, I didn't ask specifically if they would say more, because it was a professional translator. But it was quite easy they would tell you.
Thank you. And there was a question from Jacqueline for Jade. Have you had any qualified midwives who have been GEM students on your interview selection panels?
Yes, so we have. We don't tend to have many, unfortunately, because in order to have qualified midwives coming to interview, it means that they have to be not just say paid, but they have to take some time out of their job. So if they're working in the NHS, that would mean that they can't be leading a clinic, can't be looking after someone in labour to come and help us with the interviews. So it doesn't happen that often, but it does. In fact, the last interview day, I had one of my former MSc students who is a GEM midwife from GEM background, so it does happen. And obviously bearing in mind that we've worked so closely with Karina, that although we might not have someone from a GEM background that interviewing with us all the time, but the influences from this project are sort of there all the time, really. I was going to say something else, which has now escaped me. So if you want to go ahead with the next bit.
Yeah, I'm very conscious of our time, so we've got a few minutes left. So it might be that Eileen, maybe we could answer this in more detail. If you're happy to share your well, you've already shared your email with us through the registration, but it may be that we can answer this in more detail for email, perhaps. But the question is, wondering in your recruitment and project design. So I think this is both for Jade and Claire. This question. Have you noticed any differences in findings for different ethnicity groups? And Eileen was also interested to know whether when you talked about ethnic differences, is this more appropriate to refer to as racial differences, since some of the comments seem to be predominantly relating to students' appearances instead of how this intersects with their culture, religion, etc.
Yeah, so I think well we don't necessarily focus on appearance. So the example, I think if this is touching on the how would you care for someone with a headscarf, I think that's probably where this is this question's focused. We don't ask that. We don't touch on sort of appearance or anything. We give them we send them as a pre-reading a CQC report on inequalities, so to just outline the experiences with, and it's full of really interesting anecdotes of poor care that women from Black and Asian backgrounds have experienced. So we try to move away from perhaps just talking about headscarf, or maybe even doing an open day to have mannequins of different skin colors. That's all lovely, but that's just kind of a visual thing. What we wanted to do is to go beyond that, to really explore, okay, so how do you actually care for someone? So what would you do when you think that the midwife is not offering the same amount of pain relief to a Black woman compared to a Caucasian woman? So what do you actually do? So it's sort of moving away from the appearance, or sort of more like visual visual questions, but moving a bit more towards the actually what would you do, because it was really interesting. Because if you have questions like that, how do you care for someone with a headscarf, and then one of my applicants has a headscarf, then what would they say? I care for them as I would care for myself. It just wouldn't really translate. But it's really interesting now that we are interviewing lots of GEM applicants. When you show them, when we discuss the inequalities CQC report, they're like, well, actually, this is not new. However, I'm surprised that X, Y, and Z, and this is what I would do. This is my impact as a future student midwife. So yeah, I think I might have gone off on a tangent, but hopefully I'll answer that.
Thank you, Jade. I'll pass on to Helen now just to close the
Yeah,
session because I'm aware of time.
Yeah, thank you. We're literally right on time, aren't we? So all it leaves for me to say is to thank you so much, Jade and Claire. And I guess the overriding thing for me is how well you've both done in addressing these important topics through research. You know, it's not just a discussion, it's actually research that's really helping us to make changes. And so thank you very much to both of you for sharing that, and to all of our participants for their questions as well. Thanks, everyone.
Thank you.